In this video on revision total hip arthroplasty, we will learn about the surgical management of bone and soft tissue defects. Learning objectives are understanding the cause and surgical challenges in revision total hip arthroplasty, defining the goals and understanding the terminologies specific to revision scenario, basics of bone preservation and reconstruction, and the re-implantation options in total hip arthroplasty. If we look at the joint registries of different countries, the reason for revision total hip replacement can be grouped into 4 categories. Firstly, aseptic loosening, which is the result of biological responses to wear particles generated from the articular surfaces that subsequently cause osteolysis and loosening. You may find more details about this in the video on tribology of hip, part 1 and part 2. Second is dislocation. I have discussed the causes, prevention, and treatment of joint instability in an earlier video on hip joint stability. Thirdly, the fractures. Some of the common preventable causes and ways to avoid periprosthetic fractures are discussed in a video on implant fixation in total hip arthroplasty. And fourthly, infection or septic loosening. I will make a detailed presentation on this at a later date. The joint registries also give us a glimpse of some of the most common challenges encountered by the surgeons during the hip revision surgery. Important ones to remember are bony defects, soft tissue dysfunction and deficiencies, infection, other local complications such as leg-length discrepancy, dislocation, neurovascular problems, fractures and others, and systemic complications such as atelectasis, paralytic ileus, and a host of other causes. Goals of the revision surgery are 3 main things. Firstly, extract the prosthesis with minimal bone and soft tissue damage. Secondly, restore the bone stock and manage any bone deficiencies, if any. And thirdly, re-implantation to provide long-term, pain-free, stable, and a mobile hip. Now we shall look into some of the terminologies commonly used in a revision scenario. A cavitary bone defect indicates volumetric bone loss with an intact acetabular rim. A segmental bone defect indicates significant peripheral structural bone loss which causes instability without a reconstructive procedure. Acetabular augments, usually trabecular metal augments, are accessories to acetabular cup to fill the bony defect such that the original center of rotation of the hip could be restored after the revision. A jumbo cup is an acetabular cup which is over 10 millimeters bigger in size than an average cup. A cage or a multiflange cup is used when the defect cannot be reconstructed with augments and bone grafts. The polyethylene cup is usually cemented to the outer part of the cage. The inner part of the cage supports the bone graft and hence stabilizes the joint. Impaction bone grafting is a procedure to compactly fill the defects with bone graft and subsequently cement the prosthesis into the reconstructed bone. This provides dual mode stability. Initially, the cement interdigitation makes the construct mechanically stable and subsequently long-term stability is obtained by graft incorporation and bone stock restoration. Now coming to the first goal of revision THR, which is extraction of the failed implant. The acetabular cup is extracted by first removing the liner and then the screws and the cement, and then finally cup extractors are used to extract the acetabular cup. Coming to femur, the stem and the head are extracted using head extractors and the cement is removed using specialized cement removal kit, which includes osteotomes, curettes, and ultrasonic cement removers. Now, preoperatively assessing the bone loss in a failed joint replacement is challenging. Role of CT and MR, even when metal reduction sequences are used, is limited due to the presence of large metal prosthesis. X-rays are still helpful and it is easy if we could go through the radiological lines commonly used in acetabular fracture assessment. Firstly, the iliopectineal line. This represents one of the 2 borders of the anterior column of the acetabulum, and when this is combined with the line joining the anterior superior iliac spine, anterior inferior iliac spine, anterior acetabular rim, and the inferior border of the superior pubic rami, it marks the complete boundary of the anterior column. The ilioischial line marks the posterior column and the medial limit of the acetabulum by the virtue of it passing through as a part of teardrop. Teardrop is here. The quadrangular plate forms the medial wall of the teardrop, and the medial acetabular fossa forms the lateral wall of the teardrop. Sourcil is the main weight-transmitting area of the acetabulum, and the rest of the superior weight-bearing dome of the acetabulum is shown here. Similarly, the anterior and the posterior acetabular rims are also marked. Now coming back to revision THR, assessment of acetabular bone defects by Papraschi method is done on AP view of the pelvis using the following landmarks: ilioischial line or colus line, teardrop, center of the hip to the superior dome distance, and ischial osteolysis. The technical meaning of these terminologies is important to appreciate. A superior medial migration indicates an anterior column bone loss. Superolateral migration indicates posterior column bone defect. Ischial osteolysis indicates posterior wall and posterior column bone defect. Teardrop osteolysis indicates inferior aspect of anterior column defect and inferomedial acetabular bone loss. Breach in the colus line indicates medial wall defect. Now coming to Papraschi classification in particular, type 1 indicates minimal bone loss with an intact peripheral rim. There is no migration of the cup. In type 2, the columns are intact and the cup migration is under 2 centimeters. In 2A, there is superomedial migration. In 2B, there is superolateral migration. And in 2C, the cup migrates medially. Type 3 indicates significant bone loss in at least one of the columns, and hence the cup migrates over 2 centimeters. In 3A, there is superolateral migration with posterior column bone loss. And in type 3B, there is superomedial migration with both columns disrupted. This indicates the most severe form of acetabular bone loss, and pelvic discontinuity should be considered. For completion, I have mentioned the acetabular bone loss with alternate classification, which is AAOS acetabular bone defect classification. Papraschi classification for femoral bone deficiency is based on the location of the bone loss, like in metaphysis and diaphysis, residual proximal femoral bone stock, and mechanical stability offered by the isthmus. In type 1, there is minimal metaphyseal bone loss. In type 2, there is more extensive metaphyseal bone loss. In type 3, in addition to type 2, there is a deficiency in cortical bone as well. It is termed 3A if at least 4 centimeters of cortical bone is still intact, and it is called type 3B if the cortical bone is less than 4 centimeters. Type 4 indicates mechanically unsupportive isthmus with extensive metaphyseal bone loss. The AAOS femoral bone defect classification is mentioned here. The options of re-implantation in acetabular reconstruction are as follows. We have porous coated hemispherical cup with bone graft, with metal augments, cage with structural or particulate allograft, and plate with cage and allograft fixation. Now let's match up these options to the Papraschi classification. In type 1, where there is minimal bone loss with an intact rim, a routine primary acetabular cup may be sufficient. When the cup migrates but the weight-bearing rim is still intact, as in type 2A, a jumbo cup or a cemented cup with or without trabecular metal augments and with or without bone grafting may be necessary. When the superior weight-bearing dome is disrupted, an uncemented cup with augments and bone graft will be necessary. When the cup migrates medially, once again, similar to type 2A, an uncemented cup with augments and bone graft helps with reconstruction of the acetabulum. When there is significant migration with an intact anterior column as in type 3A, we can still reconstruct it in a similar way. However, cup migration is associated with disruption of both columns. It represents the most severe form of acetabular bone loss. Bone allograft, augments, cage, and cemented cup may all have to be used. Plating of the posterior column may be necessary in case of pelvic discontinuity. The options for femoral re-implantation are as follows: primary THR stem, uncemented extensively porous coated stem, long cemented femoral revision stem, impaction bone grafting, allograft and prosthesis composite, and endoprosthesis. If we match up these options with Paparazzi classification, we may conclude like this: where there is minimal metaphyseal bone loss, an extensive porous coated stem may be sufficient. However, if the metaphyseal bone loss is extensive, then along with the porous coated stem, we may have to add particulate bone grafting. When the stem stability is dependent more on the diaphyseal fixation due to extensive proximal bone loss, then an extensively porous coated stem and bone grafting alone may not be sufficient, and an impaction bone grafting and cemented stem may be necessary. This happens in type 3A. When the stem stability is compromised due to deficient cortical bone, then the options may have to be extended beyond impaction bone grafting to proximal femoral stem replacement like in type 3B. And finally, when the bone loss is so extensive that the isthmus is unsupportive, an allograft prosthetic composite or a proximal femoral replacement are the options left for the surgeon. This is the end of this video. Thank you for watching.